Hi, my name is Dr. Christopher Gibbons. I'm a scientific advisor for C&D Life Sciences. Today we're going to talk about the patient with suspected multiple system atrophy. The objectives are to discuss the role of diagnostic testing in the evaluation of patients with suspected neurodegenerative disease and the role of phosphorylated alpha-synuclein testing in patients who present with orthostatic hypotension, dysautonomia, and either ataxia or Parkinsonism. So this is a 53-year-old male who's had frequent falls. He's otherwise been healthy, but he's noticed falls increasing in frequency over the past 8 months. This was initially noticed while he was playing golf. He fell a couple of times while attempting to hit the ball off a tee, and this was about 8 months ago. It was a warm day, and he and his friends had been drinking, so the event was passed off as his being unable to handle his drink. However, this started to become more prominent, and he feels that he could not play golf at all in the past month and is worried about falling just while walking. He's had no prior medical problems and takes no medications. On review of systems, he notes more trouble with his handwriting, he has urinary urgency and frequency, endorses erectile dysfunction and constipation. His physical exam is unremarkable with the exception of his bedside orthostatic vital signs. His supine blood pressure is 142/87 with a pulse of 69. His standing blood pressure after 3 minutes is 106/69 with a pulse of 88. His general neurologic examination, his cognition is normal with a MoCA of 30 out of 30. His cranial nerves show no nystagmus on end gaze, but there's some possible impaired smooth pursuit, although it is subtle. His motor strength exam is full, 5 out of 5 throughout, but there is some subtle rigidity detected that's symmetric. His reflexes were brisk in both the upper and lower extremities at 3s. His cerebellar testing revealed dysdiadokinesia on rapid alternating movements and overshoot on finger-to-nose testing. His sensor examination is otherwise normal. His gait is wide-based and he does use the wall for support. The differential diagnosis in this case includes synucleinopathy and spinal cerebellar ataxia as part of the neurodegenerative disease category, but we certainly want to consider chronic alcohol use given his history. Cervical spine injury might explain some of his symptoms, as might B12 deficiency. Multiple sclerosis has to be considered, although it seems to be less likely. And central nervous system infections such as HIV or syphilis should be considered on any of these differential diagnosis lists. And then finally, we could consider some central nervous system process as yet to be discovered. But certainly neurodegenerative disease is probably the most likely based on his history and examination. So what would we do at this stage? We could certainly consider extensive laboratory testing for rare diseases. We might want to consider neuroimaging, both of the brain and the cervical spine. In some cases, a watch and wait approach can be considered. However, given his rapidly progressive disease, this does not seem a viable option at this stage. The SYN1 test could be considered to evaluate for the presence of synucleinopathy, and this would help support a diagnosis of multiple system atrophy. So in this case, we did order the SYN1 test. We obtained 3 small punch biopsies in the office, and these were sent for testing both of PGP 9.5, which is a marker of all axons in the skin. And what you're seeing here in this image, this is a piloerector muscle with pilomotor nerves. These are the nerves that control the muscles that cause goosebumps. In this case, the innervation is normal. Down here in the middle image, you see phosphorylated alpha-synuclein. Overlaying the same image, you get the combined merged image, which shows phosphorylated alpha-synuclein co-localized within PGP nerve fibers. So in this case, the intraepidermal nerve fiber density was normal. There was no evidence of neuropathy. However, phosphorylated alpha-synuclein shown here was detected within the skin, and this confirms a pathological diagnosis of synucleinopathy. Given the history of a 53-year-old male with significant dysautonomia and ataxia, and phosphorylated alpha-synuclein on examination on skin biopsy, the diagnosis of multiple system atrophy is now at the top of the differential. In this case, the family was well aware that there was a problem, and the examination and history were leaning towards a diagnosis of MSA based on some soft oculomotor signs, hyperreflexia, dysdiadochokinesia, and autonomic dysfunction. However, given an initial evaluation, there's always concern about making a diagnosis, particularly of a progressive fatal disease. Generally, this would require follow-up over several months to even a year before a diagnosis might be confirmed. And even in the best of cases, MSA is only diagnosed accurately, even by movement disorder specialists, about 80 to 90% of the time at autopsy. Now, there are several clinical trials that are proceeding in patients with MSA, and the earlier the diagnosis is made, the earlier they can be enrolled in such a clinical trial. And ultimately, when disease-modifying therapies become available, the earlier a diagnosis is made, the more effective disease prevention might occur. So in this case, though, the family and the patient often fear the unknown and are very relieved to have a diagnosis, even in this case where the diagnosis is a terrible one, but knowing is of great value. Now, in this case, the SYN1 test provides a pathologic diagnosis of synucleinopathy, but it does not differentiate between the synucleinopathies, which include Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, and pure autonomic failure. In this case, it's the clinical history that allows us to make the diagnosis of MSA in combination with the pathology demonstrating a synucleinopathy. So thank you for your attention, and I hope this case was of value. Please let us know if you have any questions.